Hello, everyone. My name is Claire Sexton, and today I'll be presenting over psoriasis. So before I begin, I would like to go over a general overview over the different types of psoriasis, starting with psoriasis vulgaris, which is the main type of psoriasis I'll be covering in my presentation. So psoriasis vulgaris is also commonly known as plaque psoriasis. And in this type of psoriasis, skin is inflamed and the appearance of the lesions are kind of silvery, scaly, and you can see the plaques with a clear border, often red, a red periphery. Another type is nail psoriasis, which includes the pitting and separation of the nail, along with streaks on the nail. Gutate psoriasis is another type in which there are teardrop-shaped bumps kind of found all over the skin instead of just in a concentrated area like other types of psoriasis. And inverse psoriasis is a unique type of psoriasis in which there are no scales or plaques present because it's just a rash found in the skin folds, such as the creases of the elbow or behind the knee. And the reason there are no scales is due to the fact that these are pretty moist environments. And that is why. Pustular psoriasis, these are lesions that contain pus. And then in erythrodermic psoriasis, the skin is so inflamed that the skin sheds in large sheets, resulting in large red splotchy areas throughout the body. A quick overview over what plaque psoriasis is. It's an inflammatory autoimmune skin disease. And as a result, there is an excessive proliferation of skin cells, which are keratinocytes. And individuals will often describe their skin as red, dry, itchy, scaly. And in an individual with plaque psoriasis, skin cells are replaced every 3 to 5 days versus every 28 to 30 days in a healthy individual. And plaque psoriasis, like most other types of autoimmune disorders, is not contagious, despite the past historical misunderstanding that psoriasis was associated with leprosy. This is not true. So these images give a clear look at the characteristics of psoriasis. So we have the red colored plaques here with pretty well-defined borders and silvery white dry scales. And as a result, this dry cracked skin can create itching and burning and soreness in skin that's kind of tender to the touch, along with bleeding that occurs when some of the scales fall off. Common locations for plaque psoriasis include the elbows, knees, scalp, and lumbosacral area. The exact mechanism of psoriasis is somewhat unclear. It's believed to be a combination of both genetic factors and the immune response to certain triggers. Triggers can include stress, injury to skin, illness and infection, weather, food and environmental triggers, and certain medications such as antidepressants and antihypertensive medications. Psoriasis is considered an adult disease primarily because it often first appears in individuals between the ages of 15 and 25 and lasts for their whole life. The mechanism of psoriasis is a combination of both the innate and adaptive immune response. The cells that are implicated for the innate side are the dendritic cells, macrophages, and neutrophils. And the cells on the adaptive side that are implicated are B cells and T cells. Resident skin cells are also obviously involved, and these are the keratinocytes, melanocytes, and endothelial cells. So what begins psoriasis is a regulatory T cell defect, and this will induce an inflammatory cascade in the dermis. And this inflammatory cascade leads to T cells, dendritic cells, macrophages, all migrating to the epidermis. With this, there is a release of pro-inflammatory cytokines and chemokines to the area, which is prolonging the immune response and prolonging the inflammatory response. As a result of this, the proliferation of keratinocytes continues to be stimulated, which ultimately leads to an overabundance of keratinocytes. This leads to epidermal thickening and a rapid turnover of stratum corneum. Here is a figure that kind of describes what I was just talking about, but here we have a good comparison of healthy skin versus skin and inflammation with a patient, like in a patient with psoriasis. So looking first, we can just see the difference in the thickness of the layers here, with the healthy skin kind of having a slower process of going from the basal keratinocyte to the granular keratinocyte to the corneocyte. Versus in the individual with psoriasis, we have this accelerated turnover, which leads to the greater thickness of the skin. And so, as I mentioned, this inflammatory cascade that is initiated with that T cell defect leads to the migration of dendritic cells and macrophages and T cells all to the upper layers of the dermis, the epidermis. And with this, we are having cytokines be released. It's kind of important to look at IL-17, IFN gamma, and IL-22, as these are important for enhancing and continuing the inflammatory response. And as these cytokines and other triggers are being released, it's stimulating the turnover of keratinocytes and continuing to produce this overabundance of immune response, and this overabundance of keratinocytes are ultimately being produced and leading to the thickening of the epidermal layers. Here is a comparison of normal skin versus the skin of an individual with psoriasis. And when you first look, we can obviously see the epidermal thickness is far greater in a patient with psoriasis versus the individual with the healthy individual. Also, if you look closely, there is the presence of parakeratosis, which is the phenomenon where the upper cell layers of the skin do in fact contain nuclei, which is not normal, and nuclei are not found in the upper layers of normal skin. Here too, we can see in the dermis, there are a large number of dendritic and T cells compared to the normal skin, and the presence of neutrophils in the dermal papillae regions. So psoriasis is thought to primarily be a T lymphocyte mediated disease. The psoriatic lesions contain large numbers of T cells with an increased concentration of IL-17, which is not found in healthy skin. And IL-17, along with IL-23, play key roles in the expansion and survival of T cells, which are important in the mechanism of psoriasis. Cytokines, as we saw from some of those previous images, are very important in amplifying this immune response. IL-17, IFN gamma, IL-22, TNF, these all cause increased keratinocyte proliferation and increased chemokine, cytokine, and AMP production, which kind of works as a loop that works with dendritic cells, T cells, neutrophils to perpetuate this inflammatory response. And the feedback loop is not functioning properly because it's not turning off. So we have this overstimulation of the immune response. It is believed that between 2 and 4% of the population does have psoriasis, and prevalence rates show worldwide geographic variation, with incidence rates slightly higher in Europe than the United States and lower in African and Asian countries. We have approximately current estimates of 7.5 million people in the United States who have psoriasis. And current research at the moment does believe that both men and women are affected with equal frequency. So sometimes it is difficult to diagnose moderate or mild psoriasis and differentiate that from other skin conditions such as eczema. But in addition to the characteristic rash and localized itching and pain an individual with psoriasis has, Auspitz sign and Keebner's phenomenon are ways in which your clinical provider can help diagnose psoriasis. Auspitz sign is when a scale is removed from a psoriatic lesion and bleeding occurs. And the bleeding occurs because the underlying capillaries have been ruptured. And this is a clear indication of psoriasis. Keebner phenomenon is when skin is injured. The location of that injury is where a new psoriatic lesion appears. And this is another mechanism which people can help diagnose psoriasis. There is no known cure for psoriasis, but there are medications that can help manage symptoms almost to the point where no lesions will appear on the skin. So these include steroid creams, vitamin D3 cream, UV light, biologics, and then immunosuppressive drugs. These immunosuppressive drugs can have very harsh side effects though, and UV light is from the sun is a great way to lessen the severity of the symptoms of psoriasis. And often individuals in the wintertime will have flare-ups of their psoriasis that will kind of naturally resolve themselves in the summer with exposure to the sunlight and more humidity in the environment. It's also being further researched, but they do believe that avoiding certain high inflammatory foods, one of which being red meat, can help lessen the symptoms of psoriasis as well. So current research is looking into inhibiting some of the cytokines I mentioned, such as IL-17, IL-22, to kind of use these for medications to treat psoriasis. Also, as I mentioned, psoriasis has mainly been investigated as a T cell disorder, and the role of B cells in this immune response is somewhat unclear. So more research is needed to be done on the role of B cells, and it's thought to be an area of opportunity because B cells are key to regulating the IL-10, which is an anti-inflammatory cytokine, which could possibly help treat and stop the inflammatory cascade. And then also treatment strategies are needed that don't involve prolonged immune suppression for a long period of time, as the side effects can be quite severe. Here are the references I used for my presentation, and thank you so much for listening. Please bring any questions you may have to class on Wednesday, and I would be more than happy to answer them. Thank you.